The spinal cord, a component of the central nervous system, is a large bundle of nerves that serves as a method of communication between the brain and the body. Drawn here, we have a bird's eye view of a spinal cord cross-section. At the center of the cord, we have gray matter that is comprised of neuron cell bodies. The gray matter forms a distinct shape, with 2 dorsal horns on the top of the diagram and 2 ventral horns shown on the bottom of the diagram. Surrounding the gray matter is white matter, which is made of myelinated axons. These axons form dorsal roots, shown in blue, that enter through the dorsal horn and carry sensory information from the body to the brain. These axons also form ventral roots, shown in red, that exit from the ventral horn and carry motor information from the brain to the skeletal muscles. The 2 roots merge together to form a spinal nerve. While not shown in this diagram, there are another set of roots and a spinal nerve on the other side. Overall, there are 31 pairs of spinal nerves. The spinal cord is protected by the spinal column, a series of bones comprised of 24 independent articulating vertebrae and 2 bones made of fused vertebrae. The unfused vertebrae are split into 3 regions. There are 7 cervical, 12 thoracic, and 5 lumbar vertebrae. The 2 fused regions are known as the sacrum, which is made of 5 fused vertebrae, and the coccyx, which is usually made of 4 fused vertebrae. The level at which a pair of spinal nerves leave the column indicates what part of the body it will innervate. The first 2 cervical spinal nerves innervate parts of the head, neck, and diaphragm. The cervical spinal nerves also give rise to the brachial plexus and innervate the majority of the upper extremity. The first thoracic nerve also contributes to the brachial plexus and therefore innervates a small portion of the upper extremity. Thoracic nerves largely innervate the torso, carrying sensory and motor information to and from the skin, muscle, and organs. The lumbar nerves innervate the legs, and sacral nerves are responsible for regulating bowel, bladder, and sexual function. Once the spinal nerve enters the spinal cord, the sensory information carried can travel an ascending pathway up to the brain. 2 examples of these ascending pathways would be the dorsal column medial lemniscus pathway and the spinothalamic pathway. The DCML pathway transmits fine touch and proprioceptive information to the brain. Meanwhile, the spinothalamic tract sends information about pain or temperature from the skin to the brain. Descending pathways take commands from the brain and transmit them down the spinal cord and to the body. One of these pathways, the cortical spinal pathway, helps control voluntary movement of the body. After descending the pathway, information can leave through a spinal nerve and reach the skeletal muscles. All 3 of these paths are contralateral, meaning that at some point the axons cross from one side of the spinal cord to the other. The DCML crosses in the medulla, the spinothalamic path crosses in the spinal cord, and the cortical spinal path crosses in the medullary pyramids. This is called decussation. If a spinal pathway is lesioned before the decussation, then the lesion and the affected side of the body are on the same side. If the spinal pathway is lesioned after the decussation, then the location of the lesion and the affected side are opposite. This may be important to know when assessing and diagnosing a spinal cord injury.
Spinal cord injuries are often classified by the area or region of the spinal cord they occur in. As Shine mentioned, there are 4 regions of the spinal cord. Each of these regions innervates the sensory and motor control of different regions of the body. Therefore, injuries at different levels can have characteristic deficits in each region. The lower down the injury, the less severe the deficits, because everything below a spinal cord injury or cut is lost as the connections are cut. Injuries in this region typically lead to some loss of function in the hips and legs, but individuals will usually be able to walk. There also may be a loss of bladder control that can be managed with equipment. The next region up, the lumbar region, comes with more severe impacts. Injuries in this region often lead to loss of function of the hips and the legs, and also a loss of control of urinary and bowel movements. There are specific motor and sensory deficits that can occur from injuries at each level. Injuries at L1 and L2 may lead to a loss of control of hip flexion. L3 controls knee straightening. L4 controls dorsiflexion of the foot. Finally, L5 controls extension of the toes. The next region is the thoracic region, which controls several actions that are vital for survival. Injuries in this region typically result in paraplegia, which is a loss of control of the legs. Levels T1 through T5 control muscles in the upper chest, mid-back, and abdominal muscles. These nerves and muscles help control the rib cage, lungs, and diaphragm, and muscles that help you breathe. An injury between levels T6 through T12 may result in a loss of the control of the ab and back muscles that help control balance and posture. The final region is the cervical region. It is the highest up, and injuries here can have the most severe impacts, as the cervical region is key in life-sustaining functions. The most severe cervical injuries occur at the top of this region. An injury between C1 and C4 can cause a paralysis of the arms, hands, trunk, and legs. This leads to the diagnosis of tetraplegia, which is a loss of feeling or movement below the neck and a loss in all four limbs. An injury at this level will also severely damage a person's ability to breathe on their own. Injury to the C5 region will usually allow the individual to be able to raise their arms, but the person will likely have paralysis of the hands, trunk, and legs. An injury to C6 would affect wrist extension. An injury to C7 would result in a loss of motor control of elbow extension and some finger extension. And finally, an injury to C8 would affect some hand movement, but individuals with this injury should still be able to grasp objects.
I'm going to be talking about a client that I've worked with for about a year, and he suffered from a spinal cord injury. It happened about 4 years ago from a motorcycle accident. Scott has a partial spinal cord injury, and it was an injury of the cervical spine at C8. His spinal cord injury was incomplete, meaning that it was only severed on one side, and it doesn't impact both sides of his body in the same way. Scott has loss of sensation and movement in his left leg and loss of voluntary movement in his right leg. He also has loss of sensation, movement, and muscle tone in his left hand. He has low circulation in these areas as well and can't feel heat, cold, or pain in his left leg or hand. He also maintains shoulder and arm movement and partial trunk rotation. Since the accident, Scott uses a power wheelchair because of his deficits. Some symptoms of a spinal cord injury are severe and chronic back pain, back and leg spasticity, and numbness and tingling in his right leg occasionally. Scott also has occasional joint pain in his upper body due to overuse of it because of transfers. After the accident, Scott had to be in occupational and physical therapy for 4 months at an inpatient rehabilitation center to help him recover and adjust from the accident. His therapies are used to recover from the accident, maintain muscle strength and bone density in legs, as well as work on new adapted activities of daily living. Scott has a fitted brace for his left leg to help stabilize his leg muscles to stand. He doesn't wear this all the time, but he uses it for physical therapy and exercises at home. He still goes to physical therapy appointments twice a month, and that's 4 years post-accident. He also has adaptive hand gear for his left hand. For example, he uses a hand grip for weightlifting to flex the fingers and keep his hand closed. Scott occasionally gets epidural steroid injections to reduce his nerve pain. Specifically, it helps relieve his back pain and his leg pain in his right leg. In the future, he hopes to do therapy with an exoskeleton to simulate walking. But right now, to help work on this, he's been practicing on the parallel bars and standing for long periods of time without his leg brace.
There are many ways to diagnose a spinal cord injury. Some of them include an X-ray, computerized tomography, and magnetic resonance imaging. X-rays can reveal spinal cord problems, tumors, fractures, or degenerative diseases of the spine. Computerized tomography, otherwise known as a CT scan, can provide cross-sectional images that define bone, disc, and other problems related to spinal cord injuries. Magnetic resonance imaging, otherwise known as an MRI, can look at the spinal cord and identify herniated discs, blood clots, or other masses that may be impacting the spinal cord. Once swelling has gone down after the accident and the patient is healthy enough, doctors will typically complete a full neurological exam on the patient. This helps determine the level and severity of the spinal cord injury. Doctors will typically run tests by palpation, testing muscle strength and ability to sense touch on various areas of the body. Oftentimes, surgery is needed to remove fragments of bones, fix herniated discs, remove masses, and much more. Physical and occupational therapists play an integral role in recovery once someone experiences a spinal cord injury. Therapy based on the severity and type of spinal cord injury, and unfortunately there is no way to reverse the damage of a spinal cord injury at this point, which is why therapy is so important. Physical therapy can include muscle mobility and strengthening to prevent muscle degeneration. Occupational therapy can focus on fine motor skills and working on activities of daily living. Therapists work with patients to use assistive devices such as wheelchairs, leg braces, and walkers, and sometimes communication devices if the injury is severe. Occupational and physical therapists have come up with many adaptive tools for activities of daily living. There are hundreds of examples, but some examples are handrails in showers and baths to prevent falls, hand grips or adapted utensils to help with mealtime, and boards to allow for self-transfers from wheelchairs. While people cannot fully recover from a spinal cord injury, therapy, assistive devices, treatment, and healthcare professionals can help recovery and ensure quality of life for individuals who have been impacted.